Hello, my name's Richard Harvey. I'm the Vascular Teaching Fellow here at Brighton, and I am going to be talking to you today about the basic techniques of how to tie knots, both with an instrument and with a hand tie, how to handle instruments and tissues, and then a little bit about local anaesthetic administration and diathermy. So the first thing that we need to talk to you about is how to tie a secure surgical knot. Now the basic fundamentals of this is that it should be a secure reef knot. So I shall use this jig here to demonstrate that. First of all, and the easiest way of doing it is an instrument tie. If you imagine that you have passed your stitch under the tissues, we are then going to tie it around these rubber bands. So if your instrument goes over the line of the incision, hand goes up and round once, pick up the part of the suture that is away from you, and then you bring it towards you so your hands cross over and you are left with a square knot. Keep hold with your hand that was towards you and is now away from you, and let go with your instrument. Place it back in the middle of the incision, round over the top, pick up your short end and pass it back, and there you see the classic reef knot, and this is a secure knot. Most surgeons will then put a further tie on, again into the middle, over the top, picking up that short end and bringing it back to provide you with a third square throw. Some of the complications with a suture tying involve not crossing your hands, so the bit that was away from you stays away from you, and as you can see, this does not lead to a square knot, and as a result it will not be secure. So in short, take your instrument, place it over the incision, loop over the top, bring your short end towards you, making sure your hands cross, leaving you with a square throw, back into the middle, over the top, and then taking this away from you, again making sure that it is a square throw, and then that leaves you with a secure instrument knot. We can now move on to the hand tie. Here is our jig again. Now this time the short end is away from us, so I'm going to pick up the short end with my thumb and middle finger and slide my index finger underneath that knot away from it, bring up the piece of string that is proximally to me, slide it round, grab and pull through, and you can see that my hands have crossed and that we have a secure square throw. Going back in the opposite direction, I'm now holding it with my thumb and index finger rather than thumb and middle finger, and roll those over the top, and the middle finger flicks through, grabs between middle and ring and gets pulled through away, and you can see the classic form of the reef knot there, and that is all that is needed for a secure knot. As before with the instrument tie, many surgeons will go on to do a further throw, bringing it back to create a third snug throw, and therefore a highly secure knot. Once again, of the mistakes that's made, one is to do the wrong throw going back, so even though the hands cross, you can see that this is not a square throw, and therefore this knot is unlikely to be secure. You can do the correct throw, but then your hands don't cross, and once again you can see that this is liable to slip. As a reminder, starting off away from you, you're using the thumb and middle finger with the string, with the suture lying underneath over the top of the index finger, and the index finger flicks through. You can grab with your index and middle finger and pull through with your hands crossing over, giving you a square throw. Then thumb and index finger over the top, and this time it's the middle finger and ring finger that are grabbing the thread and pulling through, hands crossing over, and there is the reef knot. Sometimes if you have a monofilament suture, then these tend to slip through the tissues. So some surgeons will in fact put two knots of the same throw on to snug it down before then putting a third throw to form a reef knot. I'm going to do a throw away to give you a square knot, another throw away to snug it down, and then your proper throw to go back to actually create your secure reef knot, to ensure that your two slip knots are held securely in position and that they do not slip any further. This is particularly important when dealing with monofilament sutures, as the amount of grip at the site of the throw itself is minimal compared to a braided suture. When holding surgical instruments, best practice is to use the ring finger and the thumb, and then automatically your index finger goes over the fulcrum of the point to give you a very steady position for stitching and holding your instruments. You can also use your hand as well, resting against the patient, to provide you with a secure base. When picking up the suture, always use a needle holder rather than your fingers, and ideally it should also be adjusted using a forceps rather than your fingers as well. Many vascular surgeons would like it to be held somewhere between half and 2/3 of the way round and pointing out at an angle of 30 degrees. This means that you can pick exactly where you would like your stitch to be placed within the bowel, within the wall of the artery, and it means you can pick your exact spot. All of the movement should be pronation and supination at the wrist. There should be no actual horizontal movement through the wall of the tissue, and you should use the curve of the needle to create one smooth semicircle of hole defect that should then be filled by your suture. When handing it back to your script nurse, the stitch should be placed like that within the forceps themselves, so that an inadvertent needle stick injury does not occur. Blades come in several different sizes. The most common that are used are a size 10 blade and a size 11 blade. Once again, they should never be picked up with the hands. They should be picked up with a set of forceps. They can be placed within onto the scalpel blade itself. We can see that that is secure and will not come loose. Again, when removing the scalpel blade, never use your hands or your fingers, always use a forceps to remove it. Size 24 blades are very large, and as are 21s, they're rarely used. Sometimes size 15 blades are used for dissecting out small subcutaneous lumps or a infected spacious cyst. 10 blades are usually used for midline laparotomy entry, incisions through the skin, and 11 blades are most commonly used for an arteriotomy or a venotomy in vascular work. Okay, so here we have our specimen. Pigskin is very nice and easy to use and is used in a number of surgical schools. The main thing is when you're making an incision to make sure that your knife is perpendicular to the skin at all times. And here we have our incision. What I'm going to do first of all is to insert a couple of ordinary interrupted sutures. There are two different types of forceps we can use. One is toothed, one is not non-toothed. Non-toothed is gentler to the inside of tissues. This is very good for the skin because it only puts the pressure through one point as opposed to spreading out a large degree of pressure over the area. As I mentioned before, this is all movement at the wrist. There's no movement at the elbow whatsoever, and the aim is to bring the stitch from the inside just using a pronation movement of the arm round and through. This can then be tied with either an instrument tie or a hand-held, a simple hand tie. and suture cut. It's important not to leave the ends of the stitch too long, as they interfere with the other sutures that are going to be placed, or too short, as they can then become loose and pulled out. So in almost at 90 degrees to the skin, and using the curve of the needle so that all of the movement is at the wrist edge. And then to do your anastomosis, making sure that to tie your knot, making sure as ever that your hands have crossed with each throw. So if we just place it or stitch through the edge of the skin, and again right at the edge of our skin, when we come back, once again using just the supination we can tie our knot and see that this in fact raises up a small area of skin at the incision edge. Another method of closing this would be to use staples. And once again, we would try and raise up the sides of the tissue and the sides of the skin so that they are pointing towards the ceiling, so that when scar contracture occurs, it flattens back down again to create a nice scar. So if we place the one stitch in like that, we can then use our forceps to grasp and pick up, and work our way along to get a nicely picked up tissue with no evidence of the skin burrowing underneath the other side. Sometimes the skin edges need to be undermined in order to provide an adequate access to get these closed. However, there is the risk that you can in fact make these flaps ischemic by doing so. The width of your elliptical incision should always be less than 1/4 of the length of your elliptical incision. Local anaesthetics are used widely in surgery, either on their own or as an adjunct to a general anaesthetic, as it means that you do not need as much opiate or depth of anaesthesia in order to maintain unconsciousness. The main local anaesthetics used can be divided into two: short-acting and long-acting. The short-acting one is most commonly used is lignocaine, and the long-acting one is mostly called bupivacaine. The length of lignocaine's action is around about 1 hour. Bupivacaine can last for up to 8 hours. This length of duration of action can be increased by adding adrenaline as well to these solutions. One problem with that is that if you put lignocaine with adrenaline into an end artery, it can render distal tissue ischemic. So lignocaine with adrenaline or bupivacaine with adrenaline should never be used for ring blocks on fingers, toes, earlobes, nose, or as a penile block prior to a circumcision, for example. Local anaesthetics are marketed as 1%, 2% or 0.5%. 1% solution would mean that there is 10 milligrams per mil of anaesthetic in that particular solution. Maximum dosages are for lignocaine 3 milligrams per kilogram. With adrenaline, this can be increased to 7 milligrams per kilogram. Bupivacaine is 2 milligrams per kilogram, increasing with adrenaline to 3 milligrams per kilogram. After drawing up your local anaesthetic with a green needle, it is usually best to instill the local anaesthetic underneath the skin with an orange needle, as these are smaller, and you can raise a small bleb underneath the skin that will then be insensate. You can then extend that insensate bleb underneath in order to provide adequate analgesia. Varying different sizes of needle and varying different sizes of cannulas available. This is a 25 gauge, which is as small as is used generally for adult surgery. This then increases in size with a 23, a 21, all the way down to a size 16 gauge or even a 14 gauge, and those are much wider, and as a result you can instill a greater volume of fluid in a much reduced space of time. Diathermy comes in two different varieties, either monopolar or bipolar diathermy. In monopolar diathermy, the current is transmitted from the end of an electrode, such as this finger switch, through the patient's body and then out through an earthing plate is usually attached to one of the patient's buttocks or thighs. In bipolar diathermy, the current will travel down one side of a set of forceps through the tissue and then back up the other side of the forceps. This is inherently safer because there is no electricity passing through the body itself. Monopolar diathermy is contraindicated in patients who've had a pacemaker or an implantable defibrillator for that very reason. But you don't get as good tissue coagulation or vaporization with bipolar diathermy as you do with monopolar diathermy. Monopolar is very useful because there are two settings. There is a cut and a coagulation setting. A cut setting uses very high frequencies of electricity in order to vaporize the tissues themselves, and in fact some surgeons use cutting diathermy to go through the skin and don't use an old-fashioned scalpel blade at any point. Coagulation is what most surgeons will use for their general dissection through areolar tissue, ensuring that they are in the correct plane, as it provides hemostasis as well as adequate dissection.